This video continuation of asthma drugs. This bronchodilator used for treatment. Remaining all the drugs used for prophylaxis to prevent second attack. So two type of patient A and patient B. Patient A required prophylaxis. The attack is already over. Now patient do not want next attack and B is in attack. So patient B we will give bronchodilator, but patient A doctor can give the various combination of this. We already discussed that mechanism of action of all prophylaxis drugs. Antibody against this IgE antibody omalizumab. Then steroid are the drugs which inhibit the synthesis of leucoderine. Steroid here there are using mast cell stabilizer. Okay, mast cell stabilizers are ketodefen and serum chromatoglycate are using. Then leucoderine antagonist are there, that is Montelukast and Shabir-Lucast. So Montelukast, Shabir-Lucast, these are the drugs used for leucoderine antagonist. Then leucoderine receptor blocker, we are using the same things only, Montelukast and Shabir-Lucast. So bronchodilator for treatment of asthma. Remaining all the drugs, leucoderine antagonist, mast cell stabilizer, corticosteroid and IgE antibody against antibody. These are the drugs used for prophylaxis for next attack. Antibody, that antibody prophylaxis drugs, antibody against antibody is omalizumab. Steroid are the drugs which inhibit the synthesis of leucoderine. Mast cell stabilizer, ketotifen and sodium chromoglycate or ketotifen. Then leucoderine antagonist, that is Montelukast, then Shabir-Lucast. Then leucoderine receptor blockers. So that one also, this Montelukast and Shabir-Lucast we can use. This one, can you see, this one is the mast cell. This is antibody, IgE antibody bind to that mast cell. IgE antibody bind to the mast cell. This is the antigen, this dot, that antigen is entering second time onwards. So this antigen is directly coming to this antibody. Second time onwards it will come and binding here. So it's giving signal to that mast cell. Okay, it will give signal to mast cells. Mast cell will ruptured. Now mast cell ruptured and the granules will come out. The granules containing leucoderine is going to its receptor. Okay, it going to its receptor presented on trachea and bronchi and causing bronchoconstriction. Here we want to prevent it at various level. First level can prevent antibody against that antibody. So first we will give omalizumab. So antibody against antibody, we will give omalizumab. Number two, stabilize that mast cell. We want to stabilize this mast cell. We can give mast cell stabilizer drugs. These are the drugs. Number three, we inhibit the synthesis of leucoderine. Okay, leucoderine synthesis we want to inhibit inside that mast cell. So we can give the steroids, corticosteroid, like that. Then antagonist, after it release, we can give xylitone. We can give xylitone. We have give xylitone. We can block the receptor, so we can give leucoderine receptor blocker, that is leucoderine receptor blockers, that is sulfuriucast, montelukast. These are used for prophylaxis. But if we want to treatment, we have to give bronchodilator. We have to give bronchodilator. Finally, bronchodilator are three types. Bronchodilator, three type of drugs. Beta 2 sympathomimetic. Second one is methyl xanthines and anticholinergic. So three type of drugs for bronchodilator. One is beta 2 sympathomimetic, then methyl xanthines and anticholinergic drugs. So three type of drugs, that mechanism of action together we want to discuss. So this one is the trachea and bronchi. This diagram is that broncho construction. This one is the dilatation. So this one is the bronchodilation. So in the muscles, trachea, okay, this part is the muscle, it having that receptor. Muscles, there are certain receptor, there are containing chemicals, that receptor containing chemicals. So some chemicals bind with receptor. Some cases of bronchoconstriction, some cases of bronchodilation. First learn that normal. This one is the normal. In our trachea bronchi who has constriction, and in our trachea and bronchi who causes dilatation. If we understand this, we can understand that mechanism of action of the three drugs. Simple. So this one is the normal trachea, neither contract nor relaxed. This one. So this is the normal trachea. Now this is contracted, this one is the dilated. Now we want contract or we want relax. For relaxation, one thing is required, that is for relaxation one thing is required, that is adenyl cyclase. Okay, for relaxation one thing is required, that is cyclic AMP causes relaxation. Who will causes relaxation? Cyclic AMP. Who synthesis this cyclic adenosine monophosphate? There is an enzyme. That enzyme name is called adenyl cyclase. Adenyl cyclase synthesis cyclic AMP. It synthesis cyclic AMP from ATP. From ATP we get cyclic AMP. The cyclic from ATP we get cyclic AMP. The cyclic AMP will secrete that enzyme adenyl cyclase. So for relaxation we want to increase or stimulate adenyl cyclase. more adenyl cyclase, more cyclic AMP, more relaxation, and cyclic AMP is destroyed by PDE, phosphodiesterase. Okay, this one destroyed by phosphodiesterase. It is inhibited or it is degraded by phosphodiesterase. So we want a drug which inhibit phosphodiesterase so that cyclic AMP is not degraded. It will remain there. So we want a drug which stimulate acetylcholine. We want a drug which inhibit phosphodiesterase. So relaxation caused only one thing, that is cyclic AMP. Contraction is done by two things. Number one, on the muscle can use that in the muscle we can see that receptor muscarinic receptor are present. Okay, in the muscle muscarinic receptor are present, so acetylcholine causes contraction. So muscles we have muscarinic receptor, so acetylcholine causes this acetylcholine causes contraction. Muscarinic receptor are present and adenosine receptor are present. Adenosine causes that contraction. Adenosine and muscarinic both causes contraction. So we want a drug that inhibit acetylcholine, that inhibit adenosine. So that normal tone, this is the contraction and this is the relaxation. So normal tone, this is contraction, this is relaxation. So the contraction, okay, so the contraction is done by two things. Number one, acetylcholine, and number two, adenosine. It causes contraction, and relaxation is done by only one, that is cyclic AMP. This one causes relaxation. Now cyclic AMP is synthesized. Okay, cyclic AMP is synthesized by adenyl cyclase. It is degraded by another enzyme phosphodiesterase, synthesized from adenyl cyclase, degraded by phosphodiesterase. Now in asthma, what we want to treat the patient with asthma more relaxation. So asthma patient, we need more relaxation. So we want a drug that stimulate adenyl cyclase so that more synthesis is there. We want that drug that inhibit phosphodiesterase, so degradation is not there. If synthesis is more, degradation is not there, acetylcholine will increase, acetylcholine contraction will increase. So beta antagonist or beta sympathomimetic drugs stimulate, okay, these beta sympathomimetic drugs stimulate this adenyl cyclase. This is the mechanism. Theophylline is the drugs that inhibit phosphodiesterase. So the beta 2 sympathomimetic drugs stimulate that mechanism. These theophylline drugs will inhibit that phosphodiesterase. So here also two, acetylcholine and adenosine, they causes contraction. We don't want contraction, so we want to inhibit this acetylcholine. So we want anticholinergic, so we need anticholinergic drugs or anti muscarinic drugs we use. So we can use the theophylline have double action. Theophylline inhibit phosphodiesterase and black adenosine receptor. Theophylline have double role, inhibit phosphodiesterase and black adenosine receptors. So this is the mechanism of three drugs. Theophylline have double action. What is the mechanism of beta 2 sympathomimetic? It stimulate enzyme adenyl cyclase. Okay, synthetic enzyme adenyl cyclase. If adenyl cyclase is increased, the cyclic will be more. Okay, cyclic AMP will be more. If cyclic will be more, relaxation will be more. Synthesis more means cyclic AMP more. This one is more means relaxation is more. So this is the mechanism of action of beta 2 sympathomimetic. What is the mechanism of this methyl xanthines? What is the mechanism of this methyl xanthine or theophylline? It have two mechanism. Number one, it inhibit that phosphodiesterase enzyme. So there is no degradation of acetylcholine. Acetylcholine is not degraded. So again, cyclic AMP is not degraded. So cyclic AMP will increase and it will causes relaxation. Number two, it blocks that adenosine receptor. Adenosine is blocked and by this also it causes relaxation. What is the mechanism of action of anticholinergic drugs? It block that muscarinic receptor. The M3 receptor presented on the drugs, the lungs having M3 receptors. So this is normal trachea. We want to contract, we want to relax. For contraction, two things are required for contraction. Acetylcholine and causes contraction. Adenosine causes contraction. Relaxation only one thing, that is cyclic AMP. Cyclic AMP causes relaxation. So in normal person currently there is a balance, not contracted, not relaxed. But whenever there is a contraction, so two causes. This one is the relaxation. This is the general physiology. In asthma, what we want? Asthma, we want relaxation. So relaxed means don't want this acetylcholine and adenosine. We want more and more cyclic AMP. By the drugs we want to such drugs which increase cyclic AMP, which block acetylcholine and which block this adenosine. The drugs block both things. We want such drugs. How does cyclic AMP synthesis and how does cyclic AMP get degraded? There is an enzyme for both. An enzyme is required. The name of that enzyme for synthesis of that the name of that enzyme is adenyl cyclase. For the degradation, that name of that enzyme phosphodiesterase. If we want to treat patient asthma, we want more and more relaxation, broncho relaxation, bronchodilation. So we want to increase cyclic AMP. So we want more and more synthesis, less degradation. Cyclic AMP should be synthesis more and more. We want it should be degrade. So we want more synthesis, give a drugs that stimulate adenyl cyclase and give a drug that inhibit phosphodiesterase. The name of the drugs which stimulate adenyl cyclase beta 2 sympathomimetic drugs. That is the mechanism of action. The name of the drugs which inhibit phosphodiesterase, that one is theophylline and methyl xanthine. For relaxation purpose, we are using three type of drugs. First one is beta 2 antagonist. It having short acting and long acting. These are the drugs list. So for relaxation, we are using three type of drugs: beta sympathomimetic drugs, methyl xanthine, and anticholinergic drugs. These beta 2 sympathomimetic drugs stimulate adenyl cyclase, so it will increase cyclic EMP. Because of here relaxation is more. Then this methyl xanthine two type of activity. First one inhibit that phosphodiesterase, so increasing cyclic adenosine monophosphate level, so it causes relaxation. Then it block that adenosine receptor and causes more relaxation. Last one is anticholinergic drugs. This one block that muscarinic receptor. So each three drugs and their mechanism of action and adverse effect we want to discuss. So first one is beta 2 antagonist drugs. So these are the drugs. Example of beta 2 sympathomimetic drugs. It stimulate acetylcholine, so increasing adenosine monophosphate, so relaxation is more. Short acting, long acting. What is the mechanism of action? Beta 2 receptor stimulation, so it will activate um, cyclase enzyme, adenylate cyclase enzyme, so enhance that formation of cyclic adenosine monophosphate, so it will causes bronchodilation. So we can use it for asthma treatment. Then adverse effect: tachycardia, palpitation. These are the things: muscle cramp, hyperglycemia, hypokalemia. These are the adverse effect. Second type of drugs, methyl xanthine drugs. These drugs main things is theophylline, aminophylline. Mechanism of action of methyl xanthine: it inhibit phosphodiesterase enzyme. So here degradation of inhibit degradation of cyclic AMP. So cyclic AMP relax smooth muscles of bronchi. So here bronchodilation. One more important function: blockage of adenosine receptor. Adverse effect: that concentration, optimum concentration 5 to 20. This arrhythmia 20 to 40. Then convulsions, concentration less than that, more than 40 microgram per ml. So optimum concentration 50 to 5 to 20. Arrhythmia 20 to 40, more than 40, producing convulsions. Third one is anticholinergic drugs. Here ipratropium bromide and duotropium bromide. So ipratropium bromide and duotropium bromide. Beta sympathomimetic produced slower response. So used for this one, used for prophylaxis, not for emergency use. So mechanism of action, this one block M3 receptor, so it will causes bronchodilation. Adverse effect: dry mouth, cough. Then the drug should be avoided in patient with prostatic hyperplasia and urinary retentions. Thanks for watching.